Hello and welcome to our November Publications podcast. I'm Ed Vital from the University of Leeds and chair of the Lupus Forum. And this month, I'm delighted to be joined by my colleague, Professor Vibeke Strand, who's an adjunct clinical professor of immunology and rheumatology at Stanford University School of Medicine in Palo Alto, California. Hi.
Hi there. Nice to see you, Ed.
Nice to see you again. So we've chosen 4 papers that came out in the last month, a range of topics again, mostly about therapeutics. I had a look at the first one of those, which is this paper on the new update to the EULAR recommendations for the management of SLE. So this one we've actually done a separate podcast on with the lead author, Dimitrios Bumpas, to go through each of the recommendations in detail, which is worth a look. But just to briefly summarize this one here, EULAR published recommendations for management of lupus not that long ago, in 2019. But we started to think, after only about a couple of years later, that things were starting to change. So there was a new license for belimumab in nephritis rather than just non-renal lupus. There was anifrolumab, there was voclosporin. There were a few other bits of evidence of the non-targeted therapies coming out as well. So there's a bit of a feeling that we needed to do an update. This one, it wasn't a complete update on everything. So some aspects like how to make the diagnosis, delivering care, all these supportive treatments, things like that, weren't revised. It's just about the treatments. But otherwise, it was still a pretty rigorous process. So the way these task forces usually work is the steering committee gets assembled. In this case, they tried to make a bit more global representation rather than just European, which I think was a good move. Then you set some PICOs, i.e. your questions you're going to try and address. There's a literature review, which is a big process. There's a research fellow employed, and it takes a lot of time. And then once the literature review's been done, recommendations are drafted and voted on to get to these final recommendations. So I thought there were a couple of things here on the non-renal part of this worth pointing out that have changed. There's still a recommendation to try and treat to target, and for that target to be remission, or if remission can't be achieved, then low disease activity. So those are SLEDAI of 0, SLEDAI 4, respectively. The prednisolone target's gone down. So it was 7.5, and now it's been lowered to 5. There was a little bit of debate about this one on the task force, because some of us thought the target should be 0. And you should only use 5 if you really have to. Whereas others thought there have been some recent studies showing you do increase flares if you taper down that last 5. So there's a bit of debate. The wording kind of says withdraw if possible, otherwise no more than 5 for long term. And then we've got hydroxychloroquine and glucocorticoids as required across mild, moderate, severe disease, all lines of therapy. But you've got these recommendations then for mild first line, second line, moderate first line, second line, and severe first line, second line. And belimumab and anifrolumab are placed quite prominently. So there's no real requirement to fail other therapies. For the mild disease, suggested to use hydroxychloroquine first, then those biologics are indicated after that. For the moderate disease and the severe disease, belimumab and anifrolumab are coming in as first-line treatment options, and then slightly lower grades of evidence for methotrexate, azathioprine, mycophenolate, CNIs as they were in the previous guideline. Another thing that if you look, not on this figure, but if you look at the guideline itself, that's different is that because most of the evidence in the new trials is on skin and joint disease or on nephritis, if it's a nephritis trial, that does mean that when you get to manifestations like neuropsychiatric or hematologic, there's still an emphasis on drugs like mycophenolate, rituximab, cyclophosphamide, because the history of use of those and the experience is greater. There was another RCT of mycophenolate that came out in the last couple of years as well. So those were the main things I thought were the key differences. There is also, I know this is on the next paper we're going to discuss, there is also recommendations on nephritis drugs. And in the nephritis drugs, there's now 6 different treatment options. So if I can think about them, it's each with glucocorticoids and antimalarials. There's mycophenolate, Eurolupus dose cyclophosphamide, NIH dose cyclophosphamide, mycophenolate and belimumab, cyclophosphamide and belimumab, or mycophenolate and voclosporin. That's it. So all 6 of them. But the thing is, not much guidance
calcineurin inhibitors, which are used very broadly in Europe.
So the guideline says voclosporin or other calcineurin inhibitors. That's true. That's true.
There's still a lot of interest in using calcineurin inhibitors throughout Asia.
That's right.
And
correct.
Although we now have voclosporin in a randomized trial, as outlined in this paper, we don't have any data to really know whether that data could be relevant to another calcineurin inhibitor.
Yeah.
And we do think that voclosporin is more unique in that it has some benefit on podocytes, which I'm not clear is shared by the other calcineurin inhibitors. What's interesting about this paper is pointing out that we have the 1 trial with belimumab, and then we have the 2 trials, phase 2 and phase 3 with voclosporin. But when you look at the data, what you really see is that, yes, there's statistical differences, and they were successful trials, but the differences between the background therapy, placebo, quote unquote, which was mycophenolate, and or in the belimumab trials, but was only mycophenolate in the voclosporin trials, we see the differences are relatively small. And meaning that they had to be large studies. We also noticed that the delta and the GFR, we really only see an increase in GFR with belimumab. With voclosporin, we see stabilization. Now, the question really is, perhaps there were more severe patients in the voclosporin study. We also know that patients with class 5 did not respond to belimumab therapy. So there really are differences in terms of using either of these 2 therapies. But the real question, I think, is when do you use which one? Now, patients may already be on belimumab, so that already makes that choice a little bit less imperative. But the other part of it is, are people really thinking that if you've got more severe or more rapid progressive GN, are you thinking voclosporin instead? And are you thinking more like the nephrologist? And of course, they're still using a fair amount of Cytoxan, which we like to avoid if we can.
Yeah.
So this is an interesting paper. Yes, they're promising new candidates, but I think what we're looking forward to are data with anifrolumab in a more effective dose, a higher dose. We're looking for the obinutuzumab phase 3 data, and it would be nice to see some complement inhibitors such as avacopan studied in lupus. What do you think, Ed?
That's right, isn't it? So the way how to choose between these drugs isn't all that clear. One of the issues I have with these comparisons is that we're looking here, when we look at the endpoints and the response measures, we're looking at proteinuria, aren't we? And
yes,
it's not an idea. It's not the outcome that's really. It's kind of a surrogate.
No.
What we're really interested in, which is long-term renal failure, but that takes a very long time to be able to observe. So we're sort of, at the moment, we're stuck with proteinuria, and we don't know if it's really telling us, whether all of these differences in proteinuria and GFR-based responses will also translate into the same types of differences in longer-term outcomes.
True, true. I think there's a real limitation in using the protein creatinine ratio. And there's a big push now for rebiopsying,
Yeah,
even when responses are evident, that we consider a rebiopsy even at 3 or 6 months to understand what's actually going on in kidneys.
yeah,
It'll be useful when we see the results of those trials. There's several underway.
yeah, that's right. And another point, I guess, that came up in the discussion of the EULAR recommendations is that currently in the EULAR recommendations, like I said, there's 6 options. So you've still got a recommendation that you could use mycophenolate on its own, for example. And I look at a table like the one in front of us, and I think, well, there's 2 phase 3 studies there showing that combining mycophenolate with one of these other drugs is superior. So should it still be a recommendation that mycophenolate on its own is a standard therapy, or should that really be only if you can't, you should give the best proven treatment in phase 3 studies if you can. If it's not possible for some reason, then okay.
I think you've got a very good point. I mean, to be fair, mycophenolate was adopted, but it was never positive in trials per se.
Yeah.
Certainly there were data to support its efficacy, but they weren't successful trials per se. So
Yeah.
I think it's an important point, since we use them anyway as background therapy to spare steroids. So most patients have already received these therapies and they're developing nephritis. Clearly they need another agent.
And also, as you've put on the slide there, it's going to change again. So obinutuzumab, I'm guessing, is going to be the first one that's going to come with a phase 3 trial outcome. But and then you'll have more choices. But we'll also, the other thing that some people talk about is whether you actually start having 4 or 5 drug regimens.
Yes.
Mycophenolate.
Especially with all the polypharmacy that lupus patients are taking anyway.
Yeah, yeah. So you might say mycophenolate, calcineurin inhibitor, and a B-cell depleting drug, and an antimalarial and steroids, and then taper it all down to 1 drug over time. Yeah.
Yeah.
Okay.
Well, I think one thing about the new EULAR recommendations is that, as they did in 2019, it was a very detailed background review, and it's very helpful from that point of view.
It's an amazing resource, actually, to have all that evidence. The next one was a review article, and it's a really useful review article, because we keep talking about trials in SLE, but as you get more drugs, you get a bit of this debate about whether skin disease in SLE and skin disease on its own, or CLE, are the same thing. Are they different diseases, and they different trials? And that we're getting quite a lot. So I think there is a bit of overlap between the two.
Yeah.
But there's also some patients.
I think the dermatologists are very clear that CLE, DLE is really different from lupus.
I mean, the DLE isn't it? But how it behaves and
right. The trials are even reviewed by US FDA in different divisions. So the CLE, DLE ones are reviewed by the derm division, and not the rheumatology transplant division. And there's a big question also whether the derm division is happy to use the CLASI. As a matter of fact, so far they have not been accepting of the CLASI, and they want an investigator global assessment, just as is used in psoriasis.
Yeah.
Which is kind of surprising, because the CLASI's been well validated and it's a much more detailed outcome measure.
That's my experience too, is that when I use the CLASI, I mean, yes, you can probably find some limitations to it, but on the whole, I find that when I do a CLASI, it really helps. I'm a rheumatologist, not a dermatologist, and it really helps guide me how to look at the skin. So what it tells you what to look for. Look at the level of erythema, look at the scale, look at the scarring, separate them all out, and how to look at different body areas. I think it really does help you have a systematic approach, and it seems to function very well in trials, whereas I feel this investigator global assessment leaves you with a lot more subjective decisions that you can
That's
make.
true. That's true. And we really don't know what one person's IgA is to another person's IgA.
Yeah, so you could have
We've
quite a
always
small
felt that
discoid
problem
lesion
with
that's causing an
psoriasis
awful
too.
lot of hassle. And it's how do you score that? Do you score it very highly because where its location is and the scarring it's causing or something is causing a big problem? Or do you rate it a bit lower because of the amount of inflammation is not as high as the next? You get these dilemmas. So anyway, there are lots. The thing is there are now lots of dedicated CLE trials. Some of them are the same drugs that are used in SLE. Some of them are drugs just for CLE, but we are getting these dedicated trials, and I think that will help, especially with drugs for people with discoid and putting them into dermatology clinics as well as rheumatology clinics. But the other thing that's really striking here, a like emerging trend, I think, is if you look at the table on the slide, we've got 1, 2, 3, 4, 5, 6, 7, 8 drugs there, and 7 of them are in innate immunity. The only one that's not is iberdomide, which iberdomide, this cereblon modulator, has kind of lymphocyte effects. But all the others are on like toll-like receptors, like sensing nucleic acids, which stimulates interferon, or blocking interferon itself with anifrolumab, or litifilimab that tries to block interferon, or the JAK1/2 inhibitors that try to stop the signaling of interferon. So you're starting to get this completely different family of drugs in CLE from what you probably would have, what we've been used to, particularly in nephritis, but also in other manifestations of lupus.
Yes, I think that's very interesting. And it says something too, because I think we know that those patients we treat who have interferon high signature, if we've checked it, we often see that their improvements are manifest in terms of their skin.
Yeah, exactly. And
so that makes a great deal of sense.
And some of these effects, some of the experience suggests that these effects for cutaneous disease can be quite dramatic. So if the deucravacitinib phase 2 study that's out, maybe it's because the class is a good outcome measure, maybe it's because deucravacitinib is a good drug, or maybe it's a combination of the two and a bit of luck. But there's a delta between placebo and one of the dose groups of like 50% difference.
Yes, no, it's large. But this wasn't DLE or CLE. It was still lupus.
In SLE patients.
And a subgroup that had the classy.
But my experience with anifrolumab in the clinic is that there can be some quite dramatic effect sizes seen. So I think
I agree.
It's right that this innate class of drugs is the most useful one for when it comes to the skin-only disease, as well as other manifestations as well, of course. Which is probably a good point to move on to the last paper that we looked at.
Yeah, so this is real-world data in anifrolumab, the small series of 45 patients. I think what's important here is that it essentially says that anifrolumab is effective in real-world use. You can see that a subgroup of patients achieved LL-DAS. You can also see that the majority of patients did not, but there were relatively few minor flares. And so this would be consistent with the efficacy we've seen of anifrolumab in phase 3. But we need real-world data for the kinds of things that we aren't able to answer in randomized controlled trials. CNS and other manifestations, hematologic of lupus. Also, we need better data in patients who've got not just nephritis, but also active lupus. And so real-world data can be very, very useful, but we need it to be in those patients that we aren't able to enroll in trials.
Yeah.
And I don't know how you set up a series such as that, but that's what we should be requesting.
I agree. I mean, that was my thought here as well, which is that when I give presentations about anifrolumab, most of the questions the audience ask me are along the lines you say: a patient with a complicated comorbidity or an overlap autoimmune disease, very young, very old, or a rarer feature of lupus, or perhaps a particular response to prior therapies. All these situations that are harder to get out of trials, and that's I mean, it's always the fascinating time with a new drug when people start reporting things like that, interesting things they've observed in the clinic, and that's how we learn. But it's also interesting as whether you could design trials a bit differently to include more of those patients, actually.
It'd be nice if we could.
So this one is kind of reassuring, but maybe not to me, not quite the really new information that we'd all want.
I mean, I'd agree. It basically said, well, patients could taper their glucocorticoids and still achieve LL-DAS.
Yeah. Okay, so that's our last paper. So that's all we've got time for today. So thank you for joining me, Vibeke. It's great to have your opinions on the latest in lupus management, as always.
Well, fun discussing with you, as always, and these were good papers.
And thanks everyone for listening. So as always, you can get these slides online to use them yourself for your journal clubs or your teaching. So there's full slide decks of the Phaneriakis and Lim papers, and single slide summaries of the other two papers, which are at lupus-forum.com. Free to download, all the contents free to access. And don't forget to register for updates on the Lupus Forum. You get an email when there's new content made available, and you can also see that if you follow us at the Lupus Forum on Twitter or LinkedIn. Thanks again, and see you next time.
Bye-bye.